Now moving on from the lumbar plexus, we will be dealing with the sciatic nerve injury, which is also a very major nerve, which involves the lower limb and actually supplies a lot of group of muscles and traverses all the way from the thigh to the foot area. And we'll briefly going through its clinical features, its treatment, and what is the sciatic nerve palsy of the total hip replacement and how it can be avoided. Usually, before the advent of total hip arthroplasty, the most common form of injury for the sciatic nerve palsy was actually trauma, which was a gunshot or a stab, and stab was actually more common than the gunshot. There's usually, if it was associated with some kind of a hematoma, especially in this area, the gluteal region, this can compress the sciatic nerve as well. Other causes include arthropathic lesions and other than this. So as we know that sciatic nerve is actually supplied with the hamstrings, and usually hamstrings, if the sciatic nerve is injured, this results in the paralysis of the hamstrings, and the flexion at the knee joint is actually lost with the loss of extension at the hip. There is a loss of sensation over the posterior aspect of the thigh. There is a foot drop which can result in a high stepping gait, because once the patient walks away, this usually results in the loss of the patient unable to dorsiflex its foot, leading to plantar flexion due to gravity, eventually causing problems with the forefoot and leading to ulcers. Therefore, usually these patients usually have a high stepping gait, so that even if the ground clearances of their foot is so much that even the foot goes into plantar flexion, this usually does not result in any kind of an injury. It could know where the peroneal nerve is damaged. It could be the problem could not be due to the peroneal nerve, but it could be due to the sciatic nerve, because it actually gives off then roots from the sciatic nerve, eventually divides in tibial and other nerves as well. Other abnormalities actually in the tibial division as well. Now there are two main problems, whether it's peroneal nerve which is more damaged or it's the tibial division is damaged. Depending upon that's the different symptoms are gonna occur. Usually it's comes with the fixed foot deformities and trophic ulcers on the sole is seen. Because why? Because they usually have a problem with the foot drop, and their foot gets repeated trauma due to being repeated trauma when they are walking, especially when their foot gets ragged with the so usually their toes gets lacerated, and a lot of injuries due to foot drop. Coming to the treatment, the options include, as you know, it all starts with whether we need to do it acutely or we need to do a delayed repair. Then suture and nerve grafting is an option if it's an iatrogenic injury. The other option is a splint for a foot drop. That is, this is the kind of a splint which has been made over here, in which the patient once lifts off its foot, the foot does not go into a plantar flexion, and there is a decreased trauma to especially the toes of the foot. Protective sensation on the sole of the foot, and usually transferring tibialis posterior is one option in which the extensor hallucis longus and extensor digitorum longus can be actually tibialis posterior, which is attached on the posterior aspect of the naviculum, that can be transferred to the extensor hallucis longus or extensor digitorum longus tendon, so that once the patient during the gait, once the patient is in the swing phase, the foot can from the plantar flexion can come into the dorsiflexion, and as a result the foot drop does not occur. Although rarely now done, but yes, in case of chronic problems, especially if it's associated, the patient had multiple infections, that this may be associated with gangrene, because once the foot ulcer develops, there's no pain and there is no situation, so there is always a very high chance of osteomyelitis associated with these ulcers. So therefore amputation may be required as well. So as you know, initially it's was mostly the gunshot and the stab, but now with the advent of an arthroplasty, especially the southern Moore approach has been frequently utilized, which is the posterior approach, and we have to especially take care of doing this surgery to not to injure sciatic nerve, which can be injured due to traction, excessive traction being applied, or this could be compressed due to under the retractor, or there may be thermal or cautery injury which could happen during the surgery. So usually it could not be, it could be complete or it could be incomplete. If it's incomplete, there is always subclinical EMG changes. There's weakness of ankle dorsiflexion or a foot drop, and usually it's associated with abnormal sensibility in the peroneal nerve. There may be a minor abnormalities in the tibial nerve as well. X-ray and bone fragment are usually what happens is that most commonly if it's cementless surgery, then the common injury is through the traction and the cautery. But if it is a cemented injury, a cemented arthroplasty was done, then the cement which is extruded out of the femur, which can usually either impinge or due to its heat, the nerve can get damaged. This is usually rarely but delayed due to if there is excessive hematoma in the post-operative period, this hematoma can compress the nerve as well. And now once the lesion has occurred, we have to analyze whether it's a neuropraxia due to hematoma or it's axonotmesis or neurotomesis. Coming to the treatment, which is indications for early operation include total sciatic nerve palsy, partial lesion associated with severe pain, a local reversible cause, that is if there's a bone fragment or cement or if there's a hematoma that can be evacuated, then it should be evacuated as early as possible so that the nerve can recover normally. In this section, we have gone through the sciatic nerve palsy, and we have seen that initially it was mainly the gunshot and stab, but now with the advent of arthroplasty, the main cause of sciatic nerve main cause of sciatic nerve injury is usually the arthroplasty-induced iatrogenic injury. This could be multiple reasons. There could be traction, there could be use of cautery, or there could be use of cement as well. The heat which is produced by the cement can also damage the nerve. Once we know that there's an associated nerve injury, the management starts from the whether it's neuropraxia, axonotmesis, or neurotomesis, and we can do some kind of options include if it's neuropraxia due to hematoma or any bony spur, that has to be removed. But if it is neurotomesis or axonotmesis, then there may require a delayed repair as well in form of nerve grafting or nerve transfers. That's all from this section. Keep watching sqadia.com. Thank you very much.